Hi, everyone. I'm Enrico Asher, founder and executive director of the Frank J. Veith International Society. Today, we'll be presenting 6 fascinating topics on open vascular techniques. We are thankful to this internationally recognized team of vascular surgeons who will deliver them shortly. Also, we're lucky to have amassed a group of superstars discussants. Thank you all. We encourage viewers' participation, and we will make every effort to respond to your written questions from the Q&A. I'm just going to share screen now, just one slide, if I can. Okay. Well, that's not it. 1 second. Yeah. No. Okay. Really? Hold on a second. Okay, good. Home file. There we go. Yeah, just a quick slide. Can you see this?
No.
No. You see? Anyway, it's a beautiful picture of Frank Veith, but if you can just look at him now, you have the same thing, okay? I think he's even looking better in person. So here we go. Let me just finish here. So I would like to take this opportunity, of course, to congratulate Dr. Veith for receiving a unique and most prestigious award from the Society for Vascular Surgery. Just this year at VAM, the leadership of the SVS announced the creation of the Frank J. Veith Annual Lectureship on issues related to PAD. I must emphasize that this honor was never before been bestowed upon a living legend in our specialty. Frank, your landmark contributions to vascular surgery, as well as your life commitment to the betterment of our specialty, have been officially recognized by the premier vascular society in the world. Frank Veith is the first surgeon to have received all 4 of the highest honors given by the SVS. He served as its president, he received the Lifetime Achievement Award, he delivered the Homans Lecture, and now the named Frank J. Veith Lecture to be presented at VAM for eternity. This is the Grand Slam of vascular surgery. Congratulations, Frank. Wow. This is just the beginning of your illustrious career. If by any chance you missed portion of this webinar, don't worry. You'll be able to access it at www.veithsymposium.org later on this afternoon. Also, a summary of this webinar will be published at the upcoming monthly issue of the Veith Symposium Bulletin. Unfortunately, Dr. Misty Humphries, a great open and endovascular surgeon from UC Davis, is not able to be with us today due to an unexpected commitment. I will sit for her. Without further delays, I would like to invite the current president and co-moderator for this session, Dr. Peter Klavitsky. Peter is the Joe M. and Ruth Roberts Emeritus Professor of Surgery, Mayo Clinic College of Medicine. Peter, please.
Thank you, Enrico. Good morning and good evening, wherever you are around the world. It's a real honor to serve this year as the president of this distinguished society named after Frank Veith. We all know that endovascular revolution transformed vascular surgery, but it's obvious now that open surgery is here to stay. The difference is that experience and teaching opportunities with open surgery seem to be less, and at the same time, the complexity of the open cases increased. So this webinar is a perfect opportunity to learn or refresh what we know about open surgical interventions. And I would like to introduce right away the first speaker, Dr. James Black, Professor and Chief of Vascular Surgery and Endovascular Therapy at Johns Hopkins University in Baltimore, Maryland. And Dr. Black is going to talk about open thoracoabdominal aneurysm repair. Jim?
Well, thanks, Peter, and thanks to Frank and Enrico also for inviting me to speak on the subject. I'm going to navigate the share screen here, and let's see how this all goes. Can you see my first slide here?
Yes.
Perfect. So we're going to run through in 6 minutes what probably is about a 6-hour operation. And oftentimes when we start with Hopkins, we think about some of our forebears, and Halstead had this line: the only weapon in which the unconscious patient can immediately retaliate upon the incompetent surgeon is hemorrhage. And that certainly applies to open thoracoabdominal repair. It's a high turnover operation, and you have to be very careful with your P's and your Q's. And I think in some way, the difficulty of the operation has engendered the push to the endovascular therapy. Indeed, I think the window for safety for many operators probably is better served in this arena. And at least initially, the hybrid debranching repair was sort of the way around the difficulty of the operation, and now, of course, is morphed into fenestrated and branched endovascular devices appropriately in many anatomies. But the strategy currently employs partial heart bypass, and that's a technique that not everyone is familiar with. It's not terribly difficult, and certainly if you've ever performed a thoracotomy, you don't have to get all the way into the pericardium, but accessing the inferior pulmonary vein and then perfusing back to the body is a reasonable approach for this. It is a difficult technique. Some people think it increases your blood turnover, but it's probably the safest way to handle the pressure of a proximal aortic cross clamp where the clock is ticking on ischemia constantly. Here's a couple pictures of different techniques. I personally don't like using the femoral vessel. I think it's small. It's often diseased. You see here the cannula placed in the left external or common iliac artery for distal perfusion. And in fact, this particular type of procedure, I was actually perfusing the pelvis and working my way up. I have left the notion of using these spider cannulas into the orifices of the individual visceral and renal bypasses. I think it's clumsy, and really the most expedient thing is to get them reperfused with either the bypass circuit distally or proximal perfusion after your proximal has been completed. When you talk about preparing the patient for surgery, I think there's a couple of things that are really have to happen. One, of course, is CSF drainage, and this has been subjected to a randomized controlled trial. And this was looking at 147 patients randomized to have a drain in place. The drain was placed post-op if they had an event. And this is the numbers. You can see without a drain, the paraplegia rate is much, much higher. When the drain was placed, most importantly, the operators were, this was Dr. Caselli's group, able to rescue some of those patients, but in fact, some of them didn't improve. And there was clearly a window of opportunity lost with the rescue protocol that you didn't get some people back that if you had the drain in place beforehand. And so simply put, it adds to the safety of the operation, adds to the prevention of really the most lethal and terrible complication. And my line is drain them all and let God sort them out when you're talking about thoracoabdominal surgery. This is some general technical notes. We have the preoperative spinal drain. If it's a very extensive aneurysm, I'll make an incision through the 4th and 7th intercostal spaces. It just gives you a nice exposure. That 4th intercostal space incision's underneath the scapula. Patient doesn't even know they have it compared to the other one. As I mentioned, we do sequential aortic clamping on partial bypass. That just means isolating the thoracic aorta for the proximal. Usually the next clamp is above the celiac where we're working on the intercostals, and then work our way down below the renals, and then lastly to the iliacs. When we're open on the visceral segment, we do cold renal flush, and we use increasingly commercial branch grafts such as the Caselli thoracoabdominal graft, particularly because a lot of our patients are Marfan's, connective tissue disorder, and avoiding the visceral patches, I think, is important. And we do intercostal reimplantation based upon motor voc potentials, which is a technique that I went into Maastricht and observed how Michael Jacobs did it, and I think that was an improvement on our program here. This is just a quick video condensing an operation down in about 2 minutes, but it shows a couple of things that we talk about already. First, you can see the patient's on partial heart bypass. The cannula here that's sitting behind this DeBakey's is sitting in inferior pulmonary vein. As you see, it's not all the way down into the pericardium. That vein can be accessed up near the lung very easily. This is sewing to a stent graft. This patient here had a degenerative aneurysm. If this was sewing to a stent graft on someone with Marfan syndrome, the aorta would be so thin you could actually see through it directly. This anastomosis, was thick. It's too partially a device. This is a medical student in anastomosis. It's so thick and easy to perform. You also notice here, particularly for converting a stent graft to open surgery, I have 2 proximal aortic cross clamps. You can see I have 2 proximal clamps also distally. And sometimes, particularly for dissected aortas, you won't be able to get the false lumen controlled with just one clamp. You'll need a second one. So here I've opened the visceral segment of the aorta. You can see a cold renal cannula here. This is just basically saline and a pressure bag from anesthesia. That's pumping in 4 degrees saline, gives you some extra protection from the renals. And this is a beveled anastomosis, as this is a degenerative aneurysm, not one based upon a genetic aortopathy. So I'm going to finish this one here, and then lastly, we'll transpose that left renal button, which is seen over here, again being cold perfused with saline, directly onto the graft. In a more extensive reconstruction, that will go directly to its own surgical bypass graft, usually off these branch surgical grafts I mentioned earlier. This is just finishing the anastomosis. That's my hand, and here's the reimplantation. The great thing about doing a video of open surgery is I can always then sort of redo that anastomosis with a couple stitches. When I take the clamp off, it looks perfect, but sometimes the buttons take some extra work. This is just sort of how it looks at the very end. As I mentioned in the essay material that will go on the website, there's a whole nother operation after this, which of course is closing the patient. This is sort of how it looks for us currently. When we're branching most of these grafts, we're going to use those individual branch grafts to avoid that long visceral suture line. This is how it looks when you sort of lay it into place. This is a Coselli branch surgical graft going to the celiac, SMA, and left renal. Here's my inflow for the bypass circuit going on the iliac. And this is a departure. We used to do this more common inclusion technique, and I think that's okay. It's expedient, but it's really not that much more expedient than doing individual grafts. These anastomoses are 10 or 8 millimeter grafts. To do each of them takes 5 or 6 minutes at most. So it's an expedient way to do the anastomosis and avoids leaving a lot of aorta behind. So I think the state of the art for us here at Hopkins is preoperative spinal drainage. I think the data there is robust and proven. MEP monitoring, we've now used in over 500 cases. It has a high negative predictive value. That is to say, if the motorvoc potentials are intact, the likelihood of having postoperative spinal cord ischemia is very, very low. We've moved to direct bypasses to the origins to avoid these visceral patch aneurysms. Cold renal perfusion with saline, I think, is also proven on a randomized trial. And distal perfusion support, I think, is up to the operator. You can do direct visceral perfusion cannulas, femoral perfusion, or you can do both. As I mentioned, I've gone to femoral or iliac perfusion. I don't do direct perfusion of the visceral and celiac. I don't feel it buys me that much time in the operation. Thank you very much.
Thank you for that very elegant presentation, Jim. And I have a few questions for you while we're waiting for other comments from our audience today. You mentioned that obviously paraplegia is a dreaded complication after these huge procedures. And you mentioned that lumbar drainage is routinely performed, of course, and that you have selected your cannulation site strategies based on your experience cannulating the external iliac or the femoral artery distally to help protect the cord. And in terms of the conduct of the operation, I think that you had mentioned also that you do the distal anastomosis after reimplanting the viscerals. Is that correct, Jim?
For the most part. I mean, if there's a real hostile chest where I'm going to have difficulty doing a full thoracic exposure, sometimes I'll start at the bottom, and then the last anastomosis will be actually the proximal at the very, very bottom of the chest. But that's a more rare circumstance. I think that it's easier for anesthesia to accommodate the reperfusion of the vessels when you're reperfusing them from above than versus reperfusing them from below, where you're relying upon the bypass for progressively taking more and more flow out of the left atrium to feed the pelvis, then the renals, then the SMA, then the celiac. That gets to be a big ask for the circuit.
I see. Okay. And in terms of the intercostal reimplantation, you had mentioned that this is motor-evoked potential based. Could you elaborate a little bit on your on that technique that you mentioned? How is that done? Is that a side branch graft off of the Coselli graft? Just talk a little bit about that.
Sure. So for the most part, we don't see the motor-evoked potentials change until you're usually past the intercostal portion of the operation. You've done the proximal, then you start to see things sort of fade almost even at the end of the operation. And then that question becomes, what do you do with it? The first thing, of course, is make sure anesthesia is not sort of changing the equation on you. We do a primarily fentanyl-based anesthesia regimen, so there's still motor potentials elicited from the monitoring technique. So you want to make sure first what they're seeing in the lower extremities are those changes a greater than 50% change in amplitude over 3 successive measurements, each 10 minutes apart. And if we see that happen, then at that point we usually act. So we act by either increasing the pressure through the circuit to help the collateral circulation, or we'll do an implantation. Usually at that point in the operation where you've already completed the whole graft, or maybe you're just finishing the distal aortic anastomosis, usually we'll go with the bucket handle technique, which was popularized actually at Penn, where you take a 12mm Dacron graft, sew it like a bucket handle on the thoracic portion, and sort of use that as and then open it along its side, and then sort of plaster that onto the side of a couple pairs of intercostals. And I don't think you have to be too aggressive about intercostal implantation. 1 or 2 pairs is usually enough. And if I have to take a guess at that point in the operation, which one, I'll almost always try and put T8 and T9 in. If feasible, I'll do T9 and T10 also.
Interesting. Yeah, we had a question from the audience. Dr. Sarek asked whether or not the MEP guides you to the specific location, or if you just empirically decide on those levels based on where you think the artery of the Adamco is.
Yeah, the studies say if you had to just pick one, it would be left T9. The left T9 intercostal on anatomic studies is most often the strongest one contributing to the spinal cord. Not to say that there can't be multiple medullary arteries. Regardless, though, I think, like I said, I don't aim to do a lot. I aim to have 2 pairs, so T8 and T9, or T9 and T10, sort of depending upon how the anatomy looks. Unfortunately, the aorta usually is taking a big turn around T10, T11, so it can get a little tricky, especially when you're trying to do that anastomosis and it's almost across the spine in the right chest.
Thank you very much, Jim. I think we will have more time at the end to discuss this, if there will be questions. I leave it up to Enrico to introduce our next speaker.
Sure. Thank you very much. Dr. Sean Lydon is known to everyone here and internationally as well. He's the professor and chairman of the Department of Surgery at the Cleveland Clinic, and he's going to talk to us about a very complex issue, the explantation of infected aorta by iliac endografts. Sean, please.
Thank you. And Frank, congratulations on the new lectureship given in your name, and welcome everybody. So explaining EVARs became a little passion of mine. Roy Greenberg, as some people know, is my med school roommate. I followed him in fellowship after doing some research time, and some of the very first Vanguards he put in, I got to take out. So I sort of developed a little love for explaining EVARs and have written a bit about it. So we're going to talk a little about the infected EVAR, which is really the more fun type. Here's the closures. I don't really think any of them are pertinent, but a lot of people look at them. So, I think failed EVAR is more common. I think if we look at the databases from Medicare, there's still an 8% rupture risk at 5 years for people in the United States having EVAR. And unfortunately, infection, especially early on, is an increasing reason that we're seeing people that are coming for failure. The infected EVAR, the treatment options are still the same that anybody would get on a board exam for open aneurysms that are infected that you're going to have to replace. You can do extra anatomic bypass, something that I think was Dr. Sarek's favorite option when he was my partner, in situ replacement of an amniotic graft, use of an aortic homograft, or using a femoral vein, which is now sort of called the NACE procedure. Dr. Claggett really didn't want it named after him, but I still call it the Claggett procedure because that's what we all called it back in the day. As we know, with stent grafts, there are a lot of different technical challenges that are unique to the stent graft, and that depending on the type of the device, the stent can become incorporated into the aortic wall and covered with the intima and pseudo-intima. That's very common in the suprarenal portion of stents. And in my experience, the Anerex device, which we don't see many of anymore. I just actually took one out yesterday, so we still see a few. Because of the stent being on the outside, it really tended to get fairly incorporated into the wall. It didn't prohibit migration, but it tends to get it fairly stuck. We know sometimes we'll see severe periodic inflammation and other types not. It's not really relative to whether there's active fixation or not. I've seen it where there is or not. And I think the really hardest thing to realize is that the suprarenal fixation, it's device specific, and there's some techniques that are each used for each device. And then there's times if it's infected, because the metal may or may not be affected, you might get away with leaving the metal behind, but getting the fabric out. So if we talk about suprarenal fixation, the barb fixation is the worst. Of all these here, I do think, in my opinion, the Zenith is probably the easiest to take out because their barbs are stainless steel and they're welded. So soldered to the endograft, and they tend to invert and bend pretty easy. The Zenith LP was a laser cut nitinol, as well as the Endurant graft and the Ovation graft, and those are much more rigid barbs, and I found they're almost impossible to evert, as we'll talk about in a second. And so to me, the toughest one I sort of get the shakes with when I have to do an explant is the Endurant. And the really great part of this week, I got to do one on Tuesday and on Thursday. So they still happen, but fortunately, neither of the ones I did this week were for infection. So I think the biggest technical tip is you need to have some wire cutters. And we'll talk about one other technique of collapsing graft. But the wire cutters, if you get the wire cutters that your cardiac surgeons have on sternotomy, there's these big things and they don't fit in the wound. We found that if you get the little dental wire cutters, and they have both a right angled one and a straight one, they're much easier to get into the small holes to cut the nitinol wires of the aortic endograft. And so they're really kind of small, but they're really able to cut through just about every device we've ever had. And so we have found that the oromaxillofacial surgeons really had the nice ones. And so if you haven't done this at your own institution, that's who you go creatively borrow and change the little tape on there so they stay in your set. Distally, you can either clamp, or a lot of times we use aortic balloon occlusion, or once you open the sac, if there's not a proximal endo leak, you can just clamp the device itself. A technique that I think works very well for the Cook device, I've not found it works for the nitinol barb devices, is taking a syringe and cutting off the end of the syringe. I think the most dangerous part of this technique is cutting off the end of the syringe with your scalpel without cutting yourself. Is probably the hardest part of the whole thing. But you can then put the syringe over top of the endograft and basically continue to crimp it down. I use silk sutures. And then once you get it down over the aorta, you can then push the syringe up, as well as pulling down on the aortic endograft and get it to come out. The one thing you need to realize is sometimes the uncovered stents will be covered with intima, and you do a nice visceral aortic endarterectomy. And I remember Dr. Caputo's third day at the clinic, he goes, well, don't you get nervous? And what happens? And I pulled up this really nice cast of the orifice of the SMA in both renal arteries. He goes, what do you do now? I said, you get the Doppler really quick and you hope to God you're not doing something else. So interesting enough, it generally sears it off flush at the origin, so you get away with it more often than not. But the first couple times you do it, it definitely does create some tightening of the sphincter. So just a couple of cases. This is a patient who actually had some inflammatory changes around a small aorta that continued to enlarge. A surgeon at another institution actually decided to put a Gore endograft in, and then it continued to enlarge and continue to have more inflammatory changes. It was clearly a mycotic aneurysm. And I know that we just talked at the annual meeting of the current SVS guidelines saying that there can be times you can put an EVAR in an infected aneurysm. I've generally found it's a nice short-term solution, and that eventually the patient expires, you're going to have to take it all out. So this patient then presented and transferred to us, bleeding out her bladder with a aortoureteral fistula. And so this is a patient with the aortoureteral fistula. I wanted to really minimize the time in the belly, and I was worried that I wouldn't be able to find the ureter. So we ended up doing an extra anatomic bypass first, and then went in and simply ligated the aorta. So it's very similar to a open surgical technique. This was a Gore device. The Gore device can simply be pushed off the aortic wall with a Kelly. The little bit of barbs on that device are not really rigid, so I've not found it very difficult to remove. The one thing similar to Jim had talked about for the connective tissue patients is many times if the device has been in a while, you can see that stent graft almost through the aortic wall. And when that happens, you want to be very careful pulling it out and trying to consider what you're going to do to buttress your anastomosis so you don't disrupt it. So this lady's now out about 10 years. I just actually saw her 2 weeks ago, and unfortunately, she's now developed a lymphoma, but her aortic infection remains at bay, and you can see her extra anatomic AX bifem graft. I generally prefer to put my femfems in the suprapubic retroperitoneal space of Retzius because I think it lies a little better and it's easier to cover. The other technique is to use femoral vein. I've not been a big fan of some of my colleagues on this call are Dr. Sherry or Dr. Kavitsky of using a homograph. And so we will use a lot of femoral vein at the Cleveland Clinic. And so at Harvested, it's a medial incision along the sartorius, mobilizing the superficial femoral artery. And you get a really nice size conduit. The average vein is somewhere between 8 and 10 millimeters in diameter. If it's bigger at the top, it's really easy to evert the vein and just cut the valves out very simply. You can see that once you have that, if you want to do an aortobiliac reconstruction, you can take 2 paces and sew them together and really create, as I did here for this infected aortic endograft, an aortobiliac repair. This is another patient that I had done a long time ago who had an aneurysm aortoduodenal fistula, and we did a similar repair with creating a pantolin graft. The one thing I got to, the other technique we've used is when you don't need to take the iliacs out and the deep femoral vein isn't long enough, we'll open up longitudinally, fold it on itself, and then sew up each side. And you can basically double the size to basically make it the size of an aortic tube graft. So you can see this is a patient that did not have an aortic endograft, but actually had a mycotic aortic aneurysm. We just simply replaced his aorta with one long piece of femoral vein that was folded over on itself to make a nice neo tube, and it looks basically the same size of an aorta. The most important thing is an omental flap. And my former fellow on this call, Dr. Ken Cherry, who came to learn endo for me, I made him come many times to my open rooms to teach me a few things because the guy had written a lot about infected aortic repairs. So I feel humbled to sit here and talk in front of him. And I would tell you that, an omental flap isn't laying the omentum on top of the graft. It's really mobilizing the right and left gastroepiploic vessels, getting the entire omentum, and then bring it through the transverse colon mesentery, where you can split it basically into 2 leaflets, where you can then wrap the omentum circumferentially around your repair. And so it's not just around the front, the back, but all the way around the sides. And when you do that, you really have a huge envelope of that. So this is the one patient I showed you earlier where we did the NACE procedure with a aortoiliac reconstruction, and you can see how that looked. So if we talk at the clinic, we've probably now done about 450 explants. The last time we really looked specifically at our infected outcomes was when we reported when we had got to 100. You can see that about 13% of the cases we did back then were for infection. That number remains pretty similar right now. The infections are a bigger procedure. If you look when we were doing them, our elective mortality is higher than our 1% for a native aorta. It's almost 10% because many times these patients are older and have been sat on a while. But if we look at in the setting of infection, our mortality had been almost 40%. And a lot of that's just due to the inflammatory state that happens with these patients. And so just you can see once again, whether it's emergent, infected, or ruptured, those patients don't do as well. We are part of the aortic consortium that put everybody's results together. You can see that there were 180 patients with aortic infected endografts. As we noted, we put in almost 18 of them, and the perioperative mortality fell to 11% when you get to bigger numbers, but the morbidity of 35%. So infected aortic grafts are bad. Infected EVARs are just as bad, especially when there's a lot of suprarenal fixation. I do think you need to get all the aortic endograft out. You may or may not have to take all the uncovered nitinol stent out. And, sometimes it can be very difficult to get out without actually making the arteriotomy up the visceral segment of the aorta. And so if you have to leave that behind to have a living patient, that makes a lot more sense. Besides the NACE procedure and AXFEM, we also do rifampin soaked Dacron grafts and do a little bit of cryografts, but it's the same options as the infected open aneurysm repair. And then really the last thing to remember is the suprarenal fixation. It just, you get a big frown on your face when you see that it's an ovation and an endurant, because those hooks are tough to deal with. So with that, I want to thank everybody for the privilege of the floor, and for my friends I got to see last week at the SVS. It was great getting back at a real meeting.
Thank you very much, Sean. This was an excellent talk, full of pearls. And we learned a lot, of course. But Dr. Vinita Chandra has very tough questions for you. As you know, she's the clinical associate professor at Stanford and one of the most productive upcoming vascular surgeons in this country. Vinita?
Thank you, Dr. Asher. Congratulations, Dr. Veith, and thank you, Dr. Glowicki, for having me here. I have to say this has been really fun already. What a great idea and what a great webinar. It's not often that we get to really dive deep and get some of these pearls. So Sean, it's always a pleasure, and you have so many pearls. Okay, so I have a couple of questions for you, and I know there's a couple of questions on the chat as well. My first question is, why even bother? If it's so dangerous to take out the suprarenal fixation and it's pretty safe to leave it in, why even try to take them out? Why don't we just leave them all in and just cut below them? And then the second question actually was also in the chat, which is, what do you do with endo anchors and how do you manage that?
So I would say that if it's an ovation or endurant, I'm most likely to leave that behind. With the Cook, I found that the syringe technique works really well, and I've never not been able to get the suprarenal fixation with the Cook. And so I think my approach is mostly device specific. The problem is that to really get all the fabric out, you're many times clamping super viscerally and cutting off, flush at the renals. And so when you're sewing and incorporating your repair, when all that metal's behind, it's a lot technically harder. So if you can take it out, great. But once you start cutting it with wire cutters, it's sort of the house of cards where it starts falling apart, and all those wire pieces can then poke holes in your graft. So, I would tell people that have not done a lot of it, I wouldn't go starting to take it out unless they had some other skilled person to teach them how to do it. But I think that makes sense. And then your second question again, Benita, was with the
Management of endo anchors.
So if you don't have to bother them, don't. Otherwise, they basically go in like a corkscrew, so you can unscrew them. But if you try to just pull them out, I found pretty much uniformly it rips the aorta and you're going to be miserable.
Yeah, thank you very much, Benita. Those are the questions from from California. Now we're going to go from New York with Dr. Veith, his comments and a question, and then we'll move along with the next speaker.
Well, first I'd like to congratulate you and Peter, Enrico, on putting this symposium together. The quality of the masters that we've heard so far is just unchallenged. And I think this webinar should be saved as a resource for trainees and other vascular surgeons. Really fantastic teaching tool. And the remarkable thing about both Jim and Sean's presentations, I didn't see a drop of blood. And I wonder how you do that, but I guess
all over my pants and the floor, so it doesn't make the photos.
My question to Sean is, do you think there's any place for the conservative approach in really bad risk patients who have an infection that Martin Molina has spoken about, of putting a catheter into the space, irrigating with antibiotic solution, but leaving the graft if there hasn't been a leak of some sort? So he has presented some fairly long-term successes with it, and I just wonder what your reaction is to that.
So we've actually done that a few times in patients we didn't feel were appropriate. Our general experience is we've gotten sometimes 3 months, 6 months, a year. We had one patient get out 2 years. But it's very unpredictable. I think if you have a less virulent organism, that might be appropriate. But I do think that you have to realize a lot of the infected cases we did were also ruptured. And so if you look at our overall mortality of 30%, they're generally a lot of times people in extremis, they're septic, and so you don't really have that ability to do that. But we have certainly put catheters in to temporize them, to drain all the pus, to sort of get them out of that floridly septic state. And we found that a nice staging approach. I just am not sure I've been convinced that it's a long-term solution. We've seen some people get out of ways, but I've not seen it uniformly successful past. We had one patient go 2 years, but uniformly our results have never been past 12 months.
Yeah, I guess my other comment, Sunita sort of struck at it a little bit. I would be much more inclined to leave the wires of the suprarenal fixation in, because you can destroy the aorta trying to get them out. But that's really, fielder's choice, I guess. And if you can get them out, it certainly makes sewing easier. You agree with that?
I do.
Great presentations, both you and Jim. Fantastic. I got to go back and watch them. They're so good.
Well, thank you very much, Frank. From the abdomen, we go up again into the chest, and it is a real pleasure to introduce the former chair of vascular surgery at Mayo Clinic and a professor of surgery at University of Virginia School of Medicine, and now in Norfolk, Virginia, Dr. Ken Cherry, who is an expert in innominate artery reconstructions, and we are going to hear the tips and tricks from Ken. If you
I'm trying
can.
to. I hit the share screen. We may need David to help me here. I don't know where it went.
Yeah.
So you click on the share screen button on the bottom,
I did, and
and then you should look for the PowerPoint window. If not, you might want to open it in advance.
where do I want to open?
The PowerPoint presentation, you can open that first and then click on the share screen and select that window.
All right. Well, that's not it. I have no idea where this thing went. Checked it. Well, Peter, rather than waste time, do you want your next speaker to speak while I'm looking for this?
Yeah, we'll be happy to do that.
I apologize. I had it up. I was looking at it before with David.
Sure. What you
Enrico?
present- Yeah, okay. So I'm very pleased to invite Dr. Clem Darling III to talk about another very interesting subject in supraceliac to mesenteric artery bypass. And as you know, Dr. Darling is a past president of the SVS and is a professor of surgery at Albany Medical College. He's also the chief of vascular surgery there. So Clem, thank you very much for coming and joining us in this webinar. Go ahead.
Well, thank you very much. It's an honor and a pleasure, and congratulations to Dr. Veith. I was having dinner with my son as we're on vacation this weekend. He said, I've heard Dr. Veith's name since I was born. So, and thanks Enrico, Peter, and sorry for Misty not being able to be here. Is it shared?
Yes.
Okay, good. I'm going to talk a little bit about our experience with mesenteric bypass. Ironically, we've seen a tremendous amount of it recently, in the sense that we've had about 120 cases in the last 2 years during the COVID experience. I'm not exactly sure why, but it seems to be coming more and more. We're seeing at least one or two a week. There are a lot of controversies in open reconstructions, whether you should use vein or prosthetic. We primarily use prosthetic, whether you should antegrade or retrograde. It talks mostly about antegrade bypass, and one or two, whether just to the SMA and to the hepatic. We tend to do 2 bypasses in most of the patients. And there's a couple of slides I'll show on some other unusual occurrences. One of the primary things is there's a tremendous collateral pathway to the mesenteric vessels when they're occluded. And luckily, many of the people survive with blockages for a while until they get acute problems. Larry Ollier wrote a nice paper in '81 showing that 2 may be better than 1 bypasses. And the Oregon group wrote about saying SMA bypasses can do just as well as if you do both. So I think the jury's still out on that, and it depends on your personal preference and what the patient needs at the time. Looking at the advantages and disadvantages, the supraceliac aorta is usually spared of disease. It's usually an excellent inflow, and it's an orthograde bypass, so it gives more hemodynamic least advantageous flow. It doesn't kink as many of the retrograde ones do, but it is physiologically much more stressful and a little bit technically challenging, because sometimes you're sewing in somewhat of a limited hole with limited exposure, and you do have ischemia below your cross clamp. Technically, it's relatively straightforward. You divide the gastrohepatic ligament, watch out for the aberrant left hepatic artery, mobilize the triangular ligament, tuck the left lobe of the liver underneath, dissect and partially divide the cruce right and left, make sure that you retract the esophagus laterally, and in order to be able to have good access to the subdiaphragmatic or paradiaphragmatic aorta. The technical concerns, we tend to use 2 clamps because we find we can open up the aperture of the aorta much better to put your bites in. A side biter you can be used. However, sometimes you can onion skin the aorta, and also you may not be able to see as well inside of it. And again, the other options are 1 bypass or 2. We usually use a 14/7 or 12/6 graft if approximately, if you're going to do 1, we'll just tie off one of the limbs. In this diagram, I think it shows you how one would use the two clamps. We usually use a Fogarty cephalad and a angled ductus inferior, so we can turn the angled ductus one way or the other, and if there's a bleeding lumbar behind it. Then we dissect. We have usually dissected out the SMA and hepatic prior to this in order to facilitate the operation. The proximal anastomosis is done with a 3/48-inch Prolene suture in a parachute fashion, again, which allows us to see the entirety of the anastomosis. I think one of the more concerning parts of this operation is the retropancreatic tunnel. It's a modified blind tunnel, which does not make you feel very comfortable. Essentially, you parallel the aorta from the top, make a hole in the mesentery, get down to the aorta, and be able to pass this using a DeBakey aneurysm clamp. A lot of times we'll place an umbilical tape through this early in the case in order to do this first, so we can, again, to expedite the operation. We've done this operation retroperitoneally, and Dr. Surak actually has some beautiful slides. I think one on the left is one I borrowed from him. In order to do this, you really have to get through the 10th interspace very posteriorly, sweep the kidney and spleen off of the diaphragm, all their attachments, in order to get it all medial encephalad, and that gives you an adequate exposure of the SMA celiac and left renal. One can do this with an anterolateral approach, as we'll see in the next slide, or a posterolateral approach. On the left, you see one of Dr. Surak's slides. With the kidney down and the left renal down, you can get about 5 to 7 centimeters out in the SMA if you do this. On the right, you can see we left the kidney up in this film and just went to the proximal portion of the SMA. I would say about 90% of the time we're doing our reconstructions nowadays, it's transabdominal, because this allows us greater facility to see the best portion of the aorta, and also because we use the retrograde the ROMS procedure in many instances, and if it doesn't work, then it allows you to go in to the next step, which would be a supraceliac bypass. Again, this is a diagram showing with the left kidney down and how the passing of the SMA bypass goes posterior to the pancreas. When you look at bypass configurations, again, antegrade or the retrograde. The reason we do antegrade mostly is because the reintervention rate is a little bit higher for the retrograde bypass, at least in our experience. There have been recent papers discounting that, but I think it's really surgeon's preference and patient condition that dictates this. Also, I think that it's important that in our armamentarium to know how to do a transaortic endarterectomy. We do this occasionally, usually the way on the top, which you make a trapdoor, usually more of a rectangular incision around all the vessels, the right, left, the right renal, the SMA and celiac, in order to do an endarterectomy. It's the key points of this is obviously you need to make sure this has a good ending point, and it's best for orificial disease and not disease that goes more distally. And this is just one case that I had to do at 2 in the morning a few years ago of where you show the supraceliac exposure. This was an occlusive plaque with a patient presented with anuria and abdominal pain, and we did an endarterectomy and then closed it One of the things I was going to mention is that we've seen a few patients with significant portal venous air or pneumatosis, and ironically, when we open them up, they do not have dead bowel. I was always taught that this is pathognomonic of dead bowel, but I'm becoming a little more suspect about it, and it hasn't stopped. It's made us be more aggressive in those patients, obviously, to get there as early as possible, because we've had favorable results with it. So our current algorithm is if no peritonitis exists, we'll attempt endo and have general surgery with the patient after successful endovascular procedures. If it needs urgent exploration, we go to ROMS. If we don't think it's a segmental lesion, we'll go to an antegrade bypass. And if the patient is Unstable, we will go to a retrograde bypass, and we always use prosthetic. We have a small series that we presented, or a series we presented at SVS a few years ago, comparing antegrade and retrograde. We did about 1,000 reconstructions, endo and open, and we looked at a small set of bypasses. Found that the operative blood loss and the bowel resection rates are about the same. Interestingly enough, it does have a very much of a female predominance. In 5 patients, we tried had attempted supraceliac cross clamps, but had ST changes as soon as we clamped, and so we aborted that and went to a retrograde procedure. And the mortalities were significant, with 32 in the antegrade and 47 in the retrograde. Were not statistically significant, but for the patient's population, it's very significant. So in conclusion, acute mesenteric ischemia remains very morbid, and this reconstruction can be complicated electively or quasi-electively. It's around 7% in our hands, but emergently it's up in the 30s. Again, our approach is dictated by patient presentation. An endo first option if the patient's stable. If it's acute or acute on chronic, we'll try ROMs and or an antegrade bypass. But really the construction is be dictated by the adequacy of the inflow. And we've actually had to, with aortic occlusions, had to do 2 bypasses off an axillary graft to the SMA in order to salvage the bowel. Thank you very much, and I'm always happy to answer any questions.
Thank you very much, Clem. This was an excellent talk, very well illustrated, great talk. And I see that you used some of the slides from Dr. Sarak, so he doesn't ask you some tough questions, but that's going to help. Dr. Sarak is the professor of vascular surgery at the Ohio State University in Columbus, Ohio. Jim, thank you very much for being with us. Please take it on. You're muted, Jim. You're muted. Thank you.
There we go. Thank you, Enrico, and thank you and Peter for having me back again. These are really fun sessions, and I'll say that as we get older in age, we look for people to go to ask questions for technical difficulties, and this panel is the people to go to. I can't tell you, several times each year I call Clem for help on things that I know. Clem, that was a phenomenal talk, and we all have learned quite a bit from you, and we continue to. I have a couple technical questions, but the first is, when do you decide to do a visceral endarterectomy as opposed to a bypass? Is there something in the anatomy or the plaque composition or what would choose you to go to that route as opposed to doing a bypass?
Yeah, that's an excellent question, because it's one of those intellectual points you really need to understand before you can try an endarterectomy. It really has to be segmental occlusive disease or have concomitant lower occlusive disease. The goal obviously is to have a good endpoint on the SMA and the hepatic or celiac axis, and to have a good point distally. So what I look for is segmental disease that goes about 1 centimeter or 2 into the SMA, into the celiac, that I think I can get out easily. If you've done a CT or some kind of image before and you see scattered atherosclerotic disease all the way through the SMA, it's probably not going to work. And it's the bailout maneuver obviously is a reconstruction, but after you've already made a hole in the aorta, it's you have to close that and go up higher and to get a better angle to do it. Sometimes you can angle it off of it, but it's a challenge. So you really have to evaluate the artery primarily with your CAT scan, but most importantly, when you're at the operation, to make sure you made the right decision. And that's actually one of the reasons why, we have those pictures, your beautiful picture and our picture from the side, because we went in there thinking maybe we'll do a endarterectomy, decided it was not a good option. So then we went for a bypass from the retroperitoneal approach. Because as you know, when you do a midline incision and rotate everything up, you're basically a retroperitoneal approach to the aorta.
That's some really good advice. And the graft and the laying of the bifurcated graft, number one, do you use PTFE or Dacron? And the second is, do you conform it? Do you choose a celiac over hepatic artery or hepatic over celiac, and what you go to? How do you handle those?
Yeah, that's actually a very important question. We tend to use PTFE. There's a theoretic advantage that it's a little more resistant to infection, but I personally don't think it makes any difference which one you use. It's what you're most comfortable with. It has to lie in an AP way in order to have the posterior portion of the bifurcated graft go right on the aorta over to the SMA, and have the anterior portion goes over the pancreas to the hepatic. If you have it side by side, like you do for a normal aortic graft, I think the chances of it kinking or causing problems are greater. So we try to put an AP with the two limbs on top of each other.
Great. We've got a chat room question from Dixon Santana. And he wants to know, how do you handle the prolonged ileus when these patients get small bowel reperfusion and edema, they have slow recovery, they've probably had ischemia to their myenteric plexus of their gut. So how do you handle those things?
Well, that's an interesting point, because if general surgery is involved and if there's a bowel resection, I would say at this point the vast majority of these patients are left open, and they come back for a second look the next day. So the chance of an ileus is high, but the chance of it causing a problem is low, because they're going to come back for a couple of washouts. In the semi-elective position, we keep them NPO for fairly, until we feel that they're comfortable. Now, in our era, we were all taught and had to pass gas before you took at the NG tube. I think a lot of this goes on how distended they are, but I would not remove the NG tube too early, and that just showed my age.
Thank you very much, Clem. I think we are going to come back to Dr. Cherry at this point, and then we can discuss further any of the presentations later. So Dr. Cherry, his slides are ready, and he's ready to talk to us about innominate artery reconstructions. Ken?
Yes, first I apologize for that miscue, and I want to thank Dr. Asher and you, Peter, and especially Dr. Veith, and congratulate Dr. Veith as the others have also. I have no disclosures. So the types of disease that require innominate artery reconstruction are primarily in this country atherosclerosis, but also Takayasu's, some radiation-induced ischemia, and also every now and again giant cell. There are lesions that simply are not amenable to endovascular techniques, such as this atherosclerotic patient you see here, or this young lady that Peter would know well, everyone at Mayo knew well, and still alive, with Takayasu's, and this was her presenting arteriogram. Certainly not a candidate for endovascular treatment. Nor was this patient with Takayasu's, who was going into left heart failure because of the long stenosis of her descending thoracic aorta. But if you look, she had disease of her great vessels and of her renals. So she had a fairly extensive operation with the great vessel reconstruction, the bypass to her infrarenal aorta, and the renal reconstructions coming from that. For just innominate artery reconstructions, you do a sternotomy. I always sort of did full sternotomies, but if the patient is thin and you feel comfortable, you can certainly do a partial sternotomy. Unlike the heart surgeons, you do want to do a hockey stick extension up along the right neck, as shown in this cartoon. You may divide or preserve the left brachiocephalic vein. Edward Kiefer, who did more of these than anyone in the world, came to visit us at the Mayo Clinic, and I couldn't figure out why his photographs and pictures were so clear, and then finally it dawned on me there was no vein in the way. And he usually divided that vein right from the very beginning. He did have one patient die of a ruptured blowout of that vein, which he very honestly told us about. Don't divide the vein if you've put a catheter in it, and don't put a catheter in it if you plan on dividing it. Very simple-minded, but little things will trip you up. You're basically going to go from the ascending aorta, and you want to be as far lateral on that wall as is possible. Usually the intrapericardial portion is free of atherosclerotic disease. And the more lateral you get, the better it is in terms of compression from the sternum when you close. We'll get to a little bit more of that. Well, we'll talk about it. In this picture, you can see that picture, you can see the graft, and you want to tunnel your grafts by and large if you've left the vein intact. Although the slide says you can be on either side, you really want to be under that vein. It does help protect your graft. The reason you want to use a single limb graft with limbs added is the size clamp you have to place on the aorta. You can add your limbs. If you use a bifurcated graft, you can see you need a larger clamp. If exigencies dictate and you have to use a bifurcated graft, make the trunk long like this. Do not make it short like you do for an infrarenal aorta. If you do that, you will get protein and proteinaceous products deposited at your bifurcation from that high flow state. You'll have to take that out or have to worry about it. Once you've got your side limbs on and you're getting ready to do your thing, relax your sternal retractor and find out exactly where they're going to lie in the neck, so that when you do your distal and other anastomoses, they go to the right position. You don't want to have your sternal retractor really wide, and then when you close things up, all of a sudden you have redundant graft everywhere and it doesn't lay in an appropriate manner. In general, well, not in general, you want to reconstruct if there's an obstruction or an occlusion, you want to reconstruct that occlusion first. It's already clamped. You've got a gimme there in a way. If you, on the cartoon on the left, if you were to do the left common first, you really don't have any good flow to the head. So it's just common sense. Reconstruct the occluded vessel first, or the most severely diseased vessel first. In general, and this is learned from hard experience, even if the patient is not symptomatic, especially for Takayasu's, reconstruct the right subclavian. You'll want some place where the nurses can get an accurate blood pressure. If you don't reconstruct that, you're going to be guessing as to central pressures. In general, we don't reconstruct the left subclavian at the first time unless there's some real ischemic problem. The left subclavian is much more difficult to get to from a median sternotomy than is everything else, as it goes back at a 45-degree angle. If events prove that you need it, you can later come back and do a carotid subclavian bypass graft through a simple supraclavicular incision a lot more easily. This is just a picture of a graft. You can see the vein has been sacrificed. The graft is on the lateral wall of the ascending aorta, and you can see it to the common carotid with the sidearm added over to the subclavian. This is one with the sidearm added to the left carotid and to the right subclavian. Just for completeness sake, since we're talking about constructions, every now and again, an endarterectomy is a very good operation. It's technically challenging, and I doubt that someone that doesn't do many is going to take it as a first step. But there are some contraindications. If there's not enough room between the left common and the innominate, you can't clamp one without clamping the other, you're not going to do it. So a common brachiocephalic trunk would be the extreme example of that. And if there's atherosclerosis at the base of the innominate involving the aorta, you wouldn't do that. The one thing I do want to add for closures on all of these is that if you close the sternum after you've done your reconstruction and it's compressing your graft, get out a rongeur and nibble away the back of the sternum and the clavicle. You're not going to cause the patient any problem, and you're going to help the patency of your graft. There is discussion about whether one should go retropharyngeal or go in front of the trachea. Most people go retropharyngeal, but I have taken care of 2 patients who've had severe dysphagia with that, and we've had to remove those grafts. So it's something to keep in mind. Most of these reconstructions can be done well if you plan ahead of time and you execute it well. And that's the end of that talk. I hope I hit 6 minutes there, Frank.
Thank you very much, Ken. Excellent presentation and excellent points and suggestions. I think I'm going to ask Vanita to come up with some burning question, if you could, Vanita.
Absolutely. Thank you guys again for an excellent presentation, Dr. Cherry. This was really, it was gold. And I agree with Dr. Veith that I'm going to have to find these recordings and look at these again. Just the pictures are really worth 1,000 words. I have a couple of questions for you. Number one, I'd just like to weigh in a little bit about your choice of graft, material, size, et cetera, and whether you alternate that or you always use sort of the same. And then I'm going to ask a bit more of a rhetorical sort of question, which is, are we training our trainees now appropriately to do these operations? I mean, you gave us a lot of great tips and tricks, but this is still quite elegant and quite complex open surgical techniques. And do we have the skills still to do these?
Well, I'll answer your first question first. I usually use Dacron. I just feel very comfortable with Dacron in this. And I like the fact that it is crimped. I usually I try to use this single limb and then add side limbs just because it's a lot less material there in the mediastinum and you don't want that to get compacted and compressed. Usually use a 10 as my source vessel and we'll take that to whichever vessel I should go to first and then add the side arms as necessary. Usually they're 8, they can be 7. I don't think that we're training our fellows in this as well as we have in the past, certainly. There's a lot of work done with hybrid reconstructions and so deep branching, so our fellows see some of that. But if someone were going to do a formal innominate reconstruction, great vessel reconstruction for primary disease, I think they would be smart to get a more experienced surgeon in the room with them to help them. I mean, there's nothing here that people can't do. It's just a matter of having seen it and feeling comfortable doing it.
Absolutely. There's a couple of quick questions in the chat. One question was the exact name of the clamp you used for the lateral ascending aorta.
I use this Cooley multi-purpose clamp. It is not a stout looking clamp, but it does not slip. Okay, so it's there. If by chance you put that clamp on and you open up your aorta and you're getting a little bit of blood, don't remove the clamp, obviously, and don't try to change it. Take a straight clamp and just put it at the edge where the clamp tips are. That's invariably where it's leaking. And if you put a straight clamp paralleling it near it, you will stop that bleeding.
That's a great trick. And do you use the same clamp if you're using the bifurcated graft, even though you advised us not to?
Do I use the same clamp? Well, you obviously, yes, but you need to pick a larger one of them. Yes. But it's a great clamp. It's it's a funny clamp. It does not look that stout, but it does not move, which is great.
These are exactly the tips that we are all scribbling down here today. So thank you. One more question, and perhaps, I don't know if we have the time for this, but what are your thoughts in terms of the current role of stenting in the presence of atherosclerosis or hybrid, as you mentioned?
Well, I think the innominate artery is certainly the right size for stenting. I mean, it's iliac artery in its sizing. And I think if people are not embolizing and they have a lesion that's amenable to it, I have no problems with it. I think, the great vessels have lent themselves to stenting. I think if people are embolizing and it's so calcific that you think you're going to shower, I think you need to think twice about that. And we have to remember that a sternotomy is not a morbid incision. It can be done and planted. So it really depends on what the lesion is like and what it's doing, I think.
Wait. Peter, please.
Enrico, you want to?
No, go ahead.
All right. So we are going to talk about infrapopliteal arterial bypasses, and Dr. Joe Mills is professor and chief of vascular surgery and endovascular therapy at Baylor College of Medicine, and he is eminently qualified to tell us how to do infrapopliteal bypasses. Joe?
Yeah, thank you, Dr. Glowicki and Asher and Veith. It's an honor to be here. And I think for most of the panelists, they will be familiar with most of these techniques, but I'm worried more than anywhere else in the body, the endovascular approaches have sort of overtaken peripheral work. And I think a lot of the open work is going to be forgotten. So I think it's important to emphasize these kind of techniques. So I don't have any conflicts of interest. So just as a general policy, there's no question for almost everything, even above the knee, if you wait long enough, but everywhere else in the leg, vein is the best. So it should be your first, second, and third choice. But sometimes there's not enough vein. So what do you do then? Do you just abandon it and use PTFE, or do you do something else, or you just do endo? So I think the way is to think about how can you modify your operation to fit the best available vein. So the two ways I break it down, one is to shorten the bypass, and the other is to lengthen the vein. So preoperative planning is huge. Increasingly, the quality of vein we see are patients who even don't have vein anymore because it's been used up increases. So mapping them out pre-op is really important. So you have some idea of what available lengths you're going to have and where you'd have to harvest and what you're going to prep. Also have some alternatives in mind in case you missed an inflow lesion and need more vein, or you need to do an angioplasty first. And so then up front, you define the ideal operation. If the vein is as good as you've mapped out, what's the proximal anastomosis? Where's that going to be? Where are you going to go distally? But then have options. Suppose you explore the vein and it turns out to be fibrotic, or you find it's got segments that you can't use. How can you deal with that? So have a plan. Choice of conduit for me, first is the ipsilateral leg. Next is the contralateral leg, as long as the patient doesn't have rest pain. We've had no trouble with harvesting vein down to the mid calf, even in people with ABIs as low as 0.5 or 0.6. It doesn't make sense to me to wait to use arm vein. Then I would use that for if that's ever needed eventually in the other leg. Splicing, we'll talk a little bit about that. And short saphenous vein can some be used. And I want to emphasize that PTFE results probably are better than we used to think, especially if you use an adjunct, and PTFE is better than a poor quality venous conduit. Vein conduit evaluation is something that I usually do that myself. I let the fellows get out the proximal and distal arteries and I mess with the vein, but it's because I think the vein's really important. So I palpate the whole length of it. You distend it very gently, don't over distend it. You can usually feel sclerotic segments, and if they resist gentle distension, there may be something wrong. One thing I actually learned from Dr. Veith was a useful thing to do, especially with arm veins, just pass a catheter through them. Then I always manually irrigate it to make sure they flow well. And then if you're going to use alternate conduits, you probably need to do more than just assess them angiographically. Most people don't have angioscopes anymore, but duplex may be useful for those cases. And this was just a segment of vein that wouldn't distend, and an otherwise normal vein that mapped appropriately. And when I cut it out, it had this sclerotic valve in it. And I think if we had left that in, we would have had a problem. For as far as the anastomoses, they try to make them long as possible and flat. One of the problems when you're sewing a smaller caliber vein to a thick-walled conduit like the common femoral artery is it can be difficult, especially at the heel anastomosis, to get big enough bites to get through the artery and not narrow your anastomosis. This is particularly true with reverse vein grafts. And so if you create your anastomosis and you see a little narrowing at the heel, that's real. Occasionally you've trapped some adventition. If you free it up, it'll pop open. But if you see that and you can't correct it by mobilizing the vein, you should make a venotomy here and patch it because you'll get burnt. So one way to avoid that, this can be caused by a very small caliber vein. And when you put your heel stitches and you just narrow it, this technique, probably 100 people have taken credit for it, but it actually appeared in Kuhn Lin's early paper on vein grafts. So I always do this, almost always. I try to find a big branch if I'm reversing the vein. And when I reverse it, I make my venotomy through that branch. And there's almost always a valve right here. I evert the vein and I cut that valve because I don't want that to cause a flow disturbance at my anastomosis. And the advantage of that technique is then when your heel stitches go in, you're not narrowing the vein at all. It's impossible. And this is an example. This is a profunda distal bypass. So we use two techniques here to shorten the bypass. One was we took it off the deep femoral artery instead of the common femoral artery. And that was to avoid previous common femoral surgery. And then you can see how the anastomosis sits up here really nice by using that heel. So I almost always do that at the proximal end if there's disparity in size between the vein and the artery. And you can sometimes do it at the distal anastomosis if it sets up well, but I don't usually plan on that because size match is not as big a problem there. Another useful technique, many patients have no forearm veins left because of IVs. So while you can splice the cephalic and the basilic, that's another anastomosis. So one technique to get around that is to lyse the valves of the basilic vein and then the the cephalic vein is a reverse component, and it saves you an anastomosis. So that was first described by Frank Legeffro and his group. So we do that sometimes. Splicing, I used to be more aggressive with splicing. I've done bypasses with as many as 4 and 5 segments. I almost never do that anymore. I think if you're going to have to use more than 2 segments, you should probably consider other alternatives. But what are the alternatives? Let's say you don't have enough. Well, one is to do an eversion endarterectomy of the SFA. So this was an example where we just didn't have enough veins. So I cut the SFA here, which was occluded, everted it, and then I sewed it end to end of the vein graft. And that got us this extra distance here so we could reach a tibial target. So that's making the conduit longer. Another example, you get a pretty big conduit here when you do that, but this works really well. So if you're only short by 10 inches or something, it's a pretty easy way to, and I'd prefer that probably over harvesting marginal vein and having to do a veno-venous anastomosis. How about tunneling? For first-time bypasses, I usually go anatomically, but if I'm going to the anterior tibial artery or if I'm using alternative vein, I usually tunnel them subcutaneously. And the reason for that is it's easier. And if it's a redo bypass, you don't have to worry about passing the tunneler through scar. And then it's easy to do surveillance on these grafts because they're right under the skin. And if you have to revise them, you can even do it under local. So this is a patient that had a bypass to the anterior tibial artery in the lateral subcutaneous plane. I also will do that to the posterior, to the perineal artery distally if we do a fibulectomy for that. And I tend to do that for all redo cases. The only issue with that is that the length required is longer. So in a first-time bypass, I'll usually tunnel through the interosseous membrane and come down to the anterior tibial that way. And it saves you length. For distal perineal artery, there's 2 ways to get to that. One is a fibulectomy, which is pretty easy. But I discovered, a surgeon from Brazil showed me this, and we subsequently did it in the lab and in a patient. You can get to the perineal artery laterally if the patient's not too big and not resect the bone at all. You just go along the fibula and rotate the leg. And I didn't think that was possible, but we did it in a cadaver and it was pretty easy. And I've subsequently done it once in a patient. So that's another option for distal exposure. The other thing I'm worried that people are losing is how to use lateral and medial and alternative approaches to all these vessels. So Dr. Veith has been a champion of that. I learned a lot of these from Dr. Porter also, and I use them all the time. We have many patients with hostile groins. And if they've actually had open surgery before and the deep femoral artery origin is well preserved, a lateral approach to the profunda is a really useful alternative. It keeps you out of the groin. It also shortens your bypass length. You can expose the popliteal artery laterally and posteriorly. And then there's posterior approaches to most of the distal vessels, which I won't go into. The other thing is short bypasses. So a lot of patients either have no disease down to the P3 segment of the popliteal, or it can be treated endo. So if you have that, a popliteal to distal bypass is one of my favorite operations because you can pick the best quality segment vein you have and make a shorter conduit. So this is a patient with trifurcation wipeout that had a BK pop to dorsalis pedis bypass. It's minimally invasive. This thing is still open at 15 years now, and skip incisions, I like to do that. And then I won't go into detail about this, but the best descriptions I've seen of these were in some work that Ken Oriel did, but you can expose, if you have a small saphenous vein, or if you're going to take vein from the other leg, you can flip the patient and you can do a pop perineal or a pop posterior tibial artery bypass from behind. This was a patient in whom I did a popliteal to perineal bypass with small saphenous vein. You can hardly see the anastomosis here. This angio was actually done so I could do something to the other leg. This isn't common, but it's something you should know how to do. Same thing with the posterior tibial artery. So if you have small saphenous and you need to do a pop distal, you can do it all from the back. Another thing, we don't do as much anymore because we usually treat the proximal segment endo, but some of these patients will have a longish SFA occlusion and then this long popliteal island and then tibial wipeout. So you can do a bypass to the popliteal island. So again, I would usually do this part endo, but you could do this with vein. If you don't have enough vein to do that, you could do it with prosthetic and then do a distal bypass off of that segment, that island, down to, this one actually had 2 pieces of vein distally. All these people should get antiplatelet therapy. Increasingly, I've been putting them all on rivaroxaban. They all get duplex surveillance. Now, what do you do? If you use poor quality vein, you're going to have bad results. So in general, we prefer vein, but there are some patients that just don't have vein. So then I'll reevaluate them and I might pursue an endo option. But if they have a pretty large proximal tibial vessel, we've had pretty good results with patches. And I think I've tried them all. So there's This is the Taylor patch. And the key to this is if you have a pretty big tibial artery, I like this approach. So you make a V in the PTFE, you sew that part to the heel, and then this vein patch has to extend beyond the anastomosis and past the heel here. It's sort of diamond shape. And this part you have to be careful with because you have multiple suture lines, but this kind of lays really nice and it's kind of a flat anastomosis. If the perineal or tibial artery is small or diseased, I like to do it this way. So Dr. Neville's popularized this, but it's basically a Linton patch. And the advantage of that is you're sewing vein to a diseased artery and then you make a venotomy and you can put the PTFE right into that. I like that a lot. Miller cuff, I've always found cumbersome. It sits up in a funny way, and Wolf collar, I don't think anybody did but John Wolf. But these two I find really useful. And there's been some argument about whether they're better or not, but our own data showed that they were less likely to have reinterventions and the limb salvage was better if they had a distal vein patch. And then recent data from the BQI shows that early PTFE results, so in higher risk patients that may not live more than 2 years or 5 years, it's not unreasonable to use PTFE rather than poor quality vein. So these results were only 1 year for patency and less than 2 years for amputation, but it's possible that early PTFE results in the modern era are better than we thought before. So I'm not a PTFE advocate, but PTFE with an adjunct is better than poor quality vein. So summary, avoid reopening old incisions. If the patient's had multiple operations in the groin, try to design a way to stay out of it. If there's nothing there you need to fix. So expose it through virgin territory. And the same thing with your distal anastomosis. If they had a failed FEM-BK pop, then do a profunded, a posterior tibial or anterior tibial bypass. And if you have a team harvest the vein, say from the other leg, this is basically like a first-time bypass because both the proximal and distal incisions are virgin and you have a good quality conduit. It makes it much easier than trying to do an endarterectomy and go back into a hostile area. I use the contralateral great saphenous vein if that patient doesn't have CLTI in that leg. It's easily harvestable down to the mid-calf. Saphenous vein is better than arm vein. I will use arm vein. The time I use that most often is for short bypasses. It's hard to get. I've done some patients that had an entire cephalic vein I could use for its whole length, but usually the forearm cephalic's not good anymore because these patients have been in the hospital a lot. Don't use poor quality vein. It's worse than PTFE. It'll fail and you'll have to do it over again and you'll regret it. So if either find good vein, shorten the operation, reconsider endo alternatives, or use PTFE with an adjunct if you really have bad vein. Another thing that helps, you can do a profundoplasty, and then sometimes if you're short vein, you can take the bypass off the profunda. So Dr. Porter always taught me this. We don't usually take our bypasses, like if we did an aorta bifem and have to add a distal bypass, I don't take the bypass off that graft limb. I take it off native vessel below that. And I think that helps. I've seen multiple patients whose inflow grafts occlude. And if your distal anastomosis for your distal bypass, your proximal anastomosis for the distal bypass came off native artery, it stays open because profunda collaterals will fill that. And I've seen these really slow flow profunda distal bypasses that stayed open even with recurrent iliac artery occlusive disease. It's pretty severe. For redo bypasses, consider tunneling them somewhere else. So subcutaneously is really good. It's easier to tunnel. It's also easier to do surveillance. So try to use vein when you can, but don't use bad vein. If you don't have enough vein, either find more or shorten the bypass. And my goal is to make autogenous grafts again. Thank you.
Thank you very much, Joe. This was just an outstanding presentation with a ton of great ideas on how to do lower extremity bypasses. We have a burning question that comes from Richard Neville, Chairman of Surgery, Innova Health System. Rich?
Thank you, Peter. Thank you very much to you and Enrico for inviting me to join this amazing panel. And I just would add my praise to, oh boy, I've just learned so much. I must say a little bit about Clem's comment. I've heard of Dr. Veith since I was an intern. So not since I was born, but since I was an intern, I've heard of Dr. Veith. So I'm not sure if that's less or more, but anyway. And Joe, that was a great talk. And Joe, I think you should be a little concerned because as we both get a little older, we're thinking more and more alike. And I'm not sure if that's good for you or for me or both of us. But it was a great talk, Joe, and great tips. And so a couple of questions. One question, what we've noticed lately is with some of the pedal loops and retrograde pedal axes, they refer them to us for a bypass, and some of the targets have been obliterated that if you look on their pre-intervention arteriograms, we could have performed a bypass. So we're still performing bypasses primarily in about 25% of our patients in our limb centers, because we think in 25.
Richard, you're muted.
Lost your sound. You're muted, Rich.
Got it. How are you dealing with, these aggressive pedal techniques in terms of your bypasses?
Yeah, it's frustrating. There's an older paper now, it's probably 8 or 10 years old, from Italy, that showed that same thing. So if you compared them before, people were doing pedal loops, most of their bypasses were to tibial arteries. Now they've been moved down to pedal arteries. And I'm still skeptical about pedal loops. So I think the people that actually need it, it's not possible. They're usually don't have a loop you can get through easily, because they're renal failure patients with extremely calcified arteries. So these ones where a floppy wire runs all the way through the pedal loop and back, and they balloon it and magically looks great. I'm really skeptical about that. But I'm concerned about losing targets. And so there's no question, if you're getting referred patients who have been done by non-vascular surgeons, overwhelmingly your targets are going to be more distal. So if they could have had a fem-pop, it's going to be a femtibial. And then I don't think my results now are as good as they used to be. And part of that is I don't do as many bypasses as I used to, but a much bigger part is the patients we get don't have the same runoff they used to, and we don't have the same conduit quality. So it's a big problem. So I think I do more endo on legs now than I do open. I think that's okay, but I'm always in the back of my mind thinking, what's my backup option for this? How many times am I going to redo this? And it sort of depends on the foot. And I always try. The problem is when you do endo, usually the target you're going after with that's the best target is also going to be the best target for bypass, right? So when I started doing endotibial work, I would try to preserve that. But usually if you just do a perineal and they really need the anterior tibial open, you're not going to get what you want, right? So I try really carefully to preserve my outflow, but it's a problem. We get increasingly patients that have poor options for redo bypass. And I know the literature's bounced around on that, but I'm pretty convinced that it hurts outcomes. Yeah,
we've certainly seen it. And then the second question, Joe, is, you even mentioned the better results we're getting now with PTFE and the patches. And we had a fistula in about 1/3 of our distal vein patches. So for the elderly patients or the high morbid patients, are you still using arm vein and lesser saphenous, or are you more prone to go to a prosthetic with a patch or a fistula?
It depends on the patient, but if you look at the basal results, there wasn't much difference up to 2 years. And so our older results in Arizona and also at the VA here, for the first 2 to 4 years, if you have a decent tibial target, PTFE with a patch works pretty well. And so, it seems easy, but harvesting vein from several sites and doing a splice and stuff is harder on patients. So I usually preserve that for younger patients. If I had a patient, what I do is if I can't do a vein bypass, I back up and say, how much. So if I'm trying to get a transmet to heal and I have pretty good endo options, I might just do endo, get the transmet to heal. And if some of that goes down, you're still okay, right?
Yeah.
But you're right. I think you have to, so that's part of the plan. If you look at the global guidelines, right? You look at the anatomy, but you also look at the patient and their life expectancy. So people that are going to be functional but have a predicted life expectancy less than 2 years, you don't need a 5-year result, right? It's probably overkill.
The other thing I'd advocate for, Joe, is what we've noticed is when we do a vein patch or prosthetic bypass, we used to put these folks all on perioperative heparin for 48 hours, and they'd get hematomas. Now with the DOACs, you can much more rapidly transition to a DOAC and avoid a lot of the downside of IV heparin to get these people onto long-term anticoagulation if you think they need it.
Yeah, I don't know if voodoo heparin works. When I don't use it, I think, damn it, I should have used it. And when I use it and it fails, I think, well, at least I tried. So, but I have started, most of my patients now I put on rivaroxaban based on the available data. And that seems to be usually that plus aspirin. And that seems to be pretty well tolerated.
Yeah, we agree 100%.
So I've been doing that. I've seen less bleeding anecdotally with that than I have with heparin.
Well, thank you very much. We could continue this because there are so many things to ask, but we have to get to the professor, Jim Stanley, who is going to talk to us about renal artery bypass in children. Jim doesn't need an introduction. He is the professor of surgery, University of Michigan Health Ann Arbor, and we are eager to listen to you, Jim. Go ahead.
Thank you very much, Peter. And Enrico, Frank, you have to be pleased with this. 130 some people tuned into this, which and are probably attentive, which probably equals the number that we might see at some of our major meetings in the audience. So this is clearly going to touch base with people. I really have no disclosures. And my perspective really comes from 218 or so children that have been under my care with refractory hypertension who undergone these open procedures. It's important, I think, to recognize that there are differences. 86% of our group had developmental disease, 14% were due to inflammatory or some ill-defined etiology. But the relevant thing is that 45% of these have their entire renal mass at risk, you know, the sum of the 33 and the 12. I think it's worth remembering that operative failures really come at a big cost. Of the papers or the procedures that I've been involved with, I think we've learned some things over time, and what we did decades ago is not necessarily what we do today. The algorithm may appear complex, but it's actually, I think, quite simple. It really relates to the location of the lesions more than the disease type. The first, midrenal stenoses, represent very minute vessels, and they're markedly deranged. They're simply not amenable to catheter interventions, as appealing as that might be. And the favored therapy for these is really an aortorenal bypass. And in this day and age, really with a segment of the internal iliac artery. I guess if you're dealing with a older adolescent, you could think about a prosthetic graft or a saphenous vein, but not in a younger child. We favor a transabdominal approach. I usually use a transverse upper abdominal approach, but midline's fine. Reflection of the intestines, sort of a generous Coker maneuver to expose the renal vasculature. As I've mentioned, the best conduit for these is really the hypogastric artery. We usually incise, if there's a branch at the end of it, one of the branches, or we spatulate the artery anteriorly and posteriorly to create a rather generous patch that's then anastomosed to an oval aortotomy, at least twice the size of the iliac artery segment that you're using. We use interrupted sutures and tie them individually as we place them, except for the last few. In the young, we use continuous suture in the older children. Distal anastomoses are also made more generous, larger, using similar spatulations. Again, the renal artery anteriorly and the graft that you're using, the hypogastric artery posteriorly. I think that's relevant. These vessels with healing will become markedly stenotic if it looks like a perfect lead pipe to a lead pipe anastomosis. We generally, or we do not use renal vein or saphenous veins in these children anymore. The better part of 80% of these become aneurysmal. Osteostenoses are different. They're the second category, and they're actually the most common of the pediatric arterial narrings. Again, these are markedly deranged arteries. They're usually only a few millimeters at the biggest in diameter. And again, they're unfortunately not amenable to a balloon intervention. Renal artery aortic reimplantations of the normal artery beyond the stenosis. You can see the little nubbins of the native renal arteries above. And implanting these into the aorta is what we favor most. And again, we tend to spatulate the renal artery anterior and posteriorly to create a sort of a generous orifice for the anastomosis. We gently mobilize the kidney medially by incising its lateral parietal attachments with reimplantations. Again, it depends a little bit on the length of available renal artery and how much is normal after the stenosis, just to lessen the tension and the anastomosis. Interestingly, the length of what tends to be a pretty short renal artery frequently with these reimplantations. The renal artery grows longitudinally as the child grows. Aortic reimplantation of the renal artery when associated with abdominal coarctations. It's complex. It always occurs in concert with doing a patch aortoplasty or thoracoabdominal bypass. Those procedures should almost always be performed first before any attention is addressed to the renal artery, because if you do the renal artery first and the patch or the bypass late and you torque the aorta, you're liable to compromise your anastomosis of the renal artery. Aortic reimplantation becomes even more complex, such as this case of children that have aortic aneurysms who have bilateral stenosis on your left. Both of those renal arteries were reimplanted into the distal aorta after the aneurysmectomy and bypass. In another similar case on your right, showing a similar reimplantation of the arteries filled by retrograde flow through these thoracoabdominal bypasses. I always look at these are not checker games. These are chess games. And you have to think a little bit before you make a move in the sequence of your procedure. Renal artery can be reimplanted the segmental vessels into the main renal artery, or as in this child, into an adjacent segmental renal artery, invariably, obviously, with interrupted sutures. And just to make the point that these cases are not checkers games, this child had her right renal artery reimplanted into the side of the SMA, given a very hostile abdominal aorta, preventing a normal aortic reimplantation. Our most recent experience involving 160 children included 27% who had a failed open or endovascular intervention prior to the University of Michigan treatment. These have been very challenging, particularly if stent placement has been used in these small vessels in younger children. So in conclusion, it's my experience, at least, and these are rare things that most people don't see in usual practices, that renal revascularization in childhood's best follows an open procedure, conventional open procedure, favoring direct reimplantations for osteostenoses or bypasses for mid and distal stenoses. And if carefully performed and thought out, 96% of these children should have a benefit. Thank you.
Peter, you're muted. Peter, you're muted. Yeah.
Yes, I hear it. I checked it. This was exceptional, Jim, but I said that your experience is extraordinary and unique. And I think the more I listen to you, the more I realize how much, how important it is to pay attention to details with this operation. Vincent Rowe is professor and chief of vascular surgery, and he is coming from the University of Southern California in Los Angeles, and Vincent is going to discuss it.
Oh, thank you, Dr. Glowicki, and thank you, Dr. Veith and Asher, for inviting me to take part in this session with so many luminaries in vascular surgery. Just one correction, I'm not the chief. Dr. Fred Weaver is still the chief of vascular surgery here. So that's just a clarification, but thank you. Dr. Stanley, every time I hear you speak on this topic, I learn so much from you. And then I also learned so much that I may have done wrong in the past with a particular patient in the pediatric setting. I just have two questions for you. One, in the cases that you talked about with where a longer conduit is needed, if hypogastric is not suitable, or have you ever seen that not be suitable? And if it's not, what would you recommend at that point? And then my second question revolves around the ever-changing endovascular field. Have you seen, because there's so many different disease processes that occur with the kids that lead to these stenoses, have you seen endovascular therapy make any motion forward in treatment of these children, either with Takayasu's, middle aortic syndrome, or what other disease process? Has there been any movement forward? And thank you for your talk. It was wonderful.
Yeah, thank you, Vince. So the first question is an important one, especially if you're considering reconstructing a vessel for the right kidney. You don't have much ability to mobilize the kidney towards the aorta, the vena cava is going to be in the way. And we've had children where we face that. I really believe an autogenous approach is better, and we've used the external iliac artery in children that are 6, 7, 8 years old, usually when they have a concomitant aortic procedure, and replace that vessel with usually a PTFE graft. So that's one substitute. I don't think that it's a cardinal sin to use vein, but it's pretty close. But there have been times, and certainly with an emergent renal revasc, to use a vein to get a kidney through so it'll be live and then deal with the aneurysmal dilation down the road. That's reasonable. But the short answer is really using a segment of the external iliac artery for a conduit. I think there's a place for endovascular. The 2 lesions I talked about, the osteo lesions, have no place for endovascular. You're going to fracture the vessel and have real difficulties. The kidney may still be alive. There's plenty of preformed collaterals. But I think for segmental lesions, I think to be able to do a selective infarct of a small wedge of a kidney and get rid of the renin secreting cells, I think that's reasonable. If you really suspect a traumatic lesion or something rather than a developmental one, I think a balloon dilation may be temporizing in a real small child. That may be better than trying to reconstruct a vessel that's 1 millimeter, 2 millimeters big. So there's a place for endovascular, but I think it's very limited. The 2 examples I showed histologic, I mean, these are teeny vessels. They're 1,000 micrometers wide. They're 1 millimeter, 2 millimeters, and the endovascular enthusiasts tend to see that big intimal hyperplasia and think, well, just clean that out. The problem is you still end up with a very hypoplastic vessel and a pressure gradient. So I think endovascular is somewhat still limited. Good question, so thank you.
Thank you.
Oh, thank you very much. Peter, you want to say a question to Dr. Stanley? No. Can you hear me?
Yes, I can hear you.
All right.
Specifically, what I was thinking is if Jim, this is combined with aortic coarctation. Do you have any opinion about the aortic expander with a balloon in children and do aortic reconstruction maybe combined with renal?
Yeah, I think that's actually a very novel and unique way of doing it. If you have a very narrow, not very lengthy aortic coarctation, you may be able to, just like a web, you may be able to mobilize enough aorta even after you've removed a couple millimeters, 3 millimeter, 4 millimeter segment aorta and do a primary end-to-end anastomosis. And of course, the Boston Children's Group, I think, has been very successful with a small number of cases where they put a balloon in and gradually expanded the balloon until the aorta gets torqued and gets longer. And the difficulty with that is the patients have to have that done for quite a while. And, the idea of someone from San Diego going to Boston and staying there for a long period of time, it just hasn't been, unfortunately, it's not part of standard practice. So people around the country could do it at a more local hospital. Technically, that group has done things very well. And they, after they distend the aorta and sew the aorta back together, removing the narrow part, that they do renal reimplantations and mesenteric reimplantations just like the rest of the world does. But it's a good idea. I think the first case reported in the New England Journal had almost retractable hypertension. They lost 1 kidney. And these are not simple, straightforward, but when it works, it's great, and it's a very thoughtful way of approaching the disease, but I don't think it fits most cases.
That's great. Great. Thank you so much. This webinar has been so fantastic. We didn't look at the time. I should have finished it 10 minutes ago, but I couldn't. I can't even finish now since Dr. Veith has a named lecture about peripheral arterial disease. I cannot close this webinar without listening to his comments because I'm sure he has some burning questions to Joseph Mill about his presentation and specifically regarding the use of PTFE that he championed for infrapopliteal geo vessels. Frank?
Well, we have a paper in progress showing that PTFE grafts, either with or without distal vein patch, can work. We have 32 patients that have gone over 4 years with a patent graft and a salvaged limb, and we'll try to get that paper out. So, but I want to make a comment about this whole webinar. I mean, this is really extraordinarily excellent webinar, and I congratulate you and Peter for putting it together. This should be a resource because of the master class of all the speakers. They're really unique, and I think this should be a resource. Maybe we can get one of the companies to support it for all trainees to watch. It really has been exemplary, and I, again, congratulate you and the speakers. Really, I learned a lot, and I'm sure everybody else did too, and hopefully many, many more vascular surgeons can get exposure to these master technicians. Thank you very much for putting it together.
Yeah, Dr. Wang, any final comment?
No, I just thank you so much for allowing me to be a part of this, and I certainly learned a lot as well. I completely agree. This should be made as a resource in perpetuity.
Thank you. Thank you so much. Peter, as usual, you're the best co-moderator I've had. And thank you for all your work as president of our society. Thank you all for participating, the presenters, discussant. I really loved it. And we see you very soon. Thank you. Have a great weekend.
Thank you very much. Great job.
Thank you, everybody.
Thanks, everybody.